what I want to emphasize here, you will see very clear cut the roles, how they do the switches. And very important, I want to emphasize something. Once the medic come, they are in white shirts. You will see they'll bring the monitor. You will see what they're doing. Very important. They'll charge the defibrillator as the CPR is commencing, and they will call out to switch. And they'll tell them, you're going to be next on compressions or you're next on the airway. I personally, in the field, right, have very seldom seen a cardiac arrest around like this. And Seattle medics, they have very good numbers, right? They have good statistics. So they did this video, and I just want to show you, right, how ultimately a cardiac arrest should run, so you guys can see it visually. Once you see it, you will be like you will get an aha moment, right? So initially, you will see here, right, they have a BLS crew. It could be a CFR crew, right, firefighters. And what they're doing is they probably have a team leader, right, a chief, crew chief, and they're running a cardiac arrest BLS style. So you have one person doing airway management, one doing compressions, and he's probably going to inform them, right, next on switch, right? So they are rotating, right, the moment the machine says analyzing, right? So the moment the AD says analyzing, right, their role is to come and switch. And the reason why they do this is the person who is doing CPR is already tired. So they switch them so that the person next on CPR has fresh, right, set of hands, and they're not exhausted of doing this, right? So ultimately, right, when you arrive on the call, it probably be two BLS providers. So you may not have, everyone here. Sometimes you may have fire crew there, so you utilize them, right? So initially, what I want to emphasize is it's quality CPR and rotations are being conducted, right? When do they rotate? The moment the machine says analyzing. They don't wait for the machine to say charging, shock, and then they're like, oh man, we got to switch. They do it automatically, right? So let me fast forward this when the medics arrive, and I want to show you something. So, right? So the medics arrive, and you see, right? They're still utilizing their own AED, right? Because you want to utilize, perhaps you come in at 1 minute mark, right? And the next minute, their AED will say, analyzing, maybe shock advice. If you disconnect it, right, you lose that time frame. So they will utilize their own AED while they're connecting everything. You notice, right, they're working together, right? One person is on the airway, the other person is setting up IV access, and he's setting up the monitor. The BLS, right, is spiking their bag, so everybody's being utilized. See, he's charging while the compressions are conducted, so the time is not wasted off the chest.
Somebody in position for me, please. That's 2 minutes. Get ready to rotate. You go ahead and hop out. Clear. We have back on the chest, please.
Right, so they will initiate access. So the whole purpose of me showing you this, right? You notice they charged the monitor while CPR was conducted, right? They didn't say stop CPR, right? Then charge the monitor, because if you look, right, let's say I charge this monitor right, to 220, and you will see the time it takes, right? So if I'm charging this and no CPR is conducted, that's a pretty long time frame. Everybody would agree with me? Right? So what they do is they pre-charge it, right? And now, let's say if I see the patient, he has a shockable rhythm, I check the pulse, there's no pulse, right? I can go ahead and say everyone's clear and shock. But let's say this was a perfusible rhythm, and the patient did have a pulse. There's another button here that says disarm, right? So I'll click disarm. I don't need to defibrillate because patient has a pulse, right? And I don't need to do this. Is that clear, right? So the whole purpose of this is that we want to maximize time on chest, minimize time off the chest. Right? The next thing I want to show you, right, if that's clear, I want to go through some of the algorithms with you so that you guys understand. This is AHA. Why do we utilize AHAs? Because if you look at your REMAC protocols, they all say, right, begin CPRs per AHA guidelines. So all of this is based on your American Heart Association guidelines. There were some changes, so I'm going to give you the new protocols, right, and I'll explain to you what were the slight changes in the 2022 with the COVID. Right? So they emphasize in the beginning, right, this is your BLS guidelines, they emphasize PPE, right, because aerosolized particles, you could get sick, and they also utilize a HEPA filter, basically put this for your BVM, right, and the face mask. so that the particles, less particles will come through. You'll also employ this if you were to intubate a person, right? You'll utilize the HEPA. So the major difference is that the implemented is basically PPE, right? PPE protection and the HEPA filter, right? But in terms of your sequence, everything stays the same, right? So the BLS protocols, right, that we have here, right? You come on scene, you verify that your scene is safe, put the PPE on, check the pulse, right? No pulse, you initiate CPR. And remember, for the AHA, we said we utilize CAB mnemonic, right? And I was emphasizing, what does C stand for? Compressions, right? It doesn't mean circulation. It means the moment you determine there's no pulse, you start with compressions first, right? Then airway, then breathing, right? So C stands for compressions first, right? But this is your BLS algorithm. But here we're going to focus on your ACLS stuff. But today, what I want to focus on is not per se the drugs or your ALS interventions. What I want to focus on is the following. I want the person who is the team lead be the team leader. Their job is to establish when the cardiac arrest, happened, the time frame, right? What if there were any providers there, if anything they done, how many shocks they delivered, and then you want to run your crew, right, in a way that's the most beneficial to maximizing time on the chest. So good switches, right? Charging the defibrillator while CPR is conducted, informing your teammates that I'm not going to shock, I'm going to charge it up, right? And when the time comes, so you're keeping track of time. When the 2-minute comes, you tell them, right, you're next on compressions, right? And you're going to deliver the shock. So I want to go through this. I'm not so much worried about the drugs and airway and all this advanced airway stuff now, because if you don't have the sequence, right, down, and you're not running your team, the team will run you, or the team will run itself. And then the outcomes are very poor, right? So the next thing, so this will be your ALS algorithms. I'm going to show you some examples what we're going to do. This is just same algorithm in this circle-wise fashion. So they basically want to emphasize here that, right, your continuous CPR and compressions are the top tier, right, and your defibrillation is the top tier. This stuff here, in terms of your drug therapy, advanced air management, all of this is not the highest priority. The highest priority is, again, CPR, early defibrillation, right, and something known as chest compression fracture. So, with that in mind, I'm going to show you for AHA, ACLS testing. You're going to get these checklists, right? Can you guys see this line here? Mm-hmm. Right, so it says audio-visual feedback device is required for accuracy. Everybody see that? So what is audio-visual feedback? A mannequin, right? Huh? What is that? The puck? The puck, okay. So audio-visual feedback tells you as the student who is practicing how effective your CPR is. It tells me as the instructor if you're actually following the guidelines. So when you're actually going to be doing this, you're going to be objectively graded. What I mean by that, when you're going to be tested, it's not like, oh, it kind of looks you did 2 inches, it kind of looks like you did 100 to 120 a minute, right? It has to be precise, right? Can I get any volunteer to do CPR? Anyone want to do CPR? Come. So when this device works, right? So do a few compressions, and I'll show you on the screen. So bring the screen here, so you guys can see. Yep.
Yeah, just do it.
No, just do a few compressions. You're gonna turn. Go ahead.
Cindy's safe.
All right, go ahead. Stop it. All right. So what we're doing, we're basically connecting the mannequin to the iPad, right? So once it's connected, right, we see a little N12. We say, okay, start. And then what we're going to be doing is we're gonna have CPR. We're gonna do with BVM ventilations, and so we set this to start. All right, Milan, do a few compressions. So as he's doing compressions, I want you guys to look at the screen. So now try to do shallow compressions, like poor compressions, not all the way down. You see how this bar doesn't go all the way down? Now go all the way down, but don't have good recoil, have bad recoil. Go all the way down, but bad recoil. See, it doesn't go all the way up, right? Now, do it super, super fast. So you see how this dial goes all the way to the right? So he's above the normal, 100 to 120. Now do very slow compressions. All right. So now this needle drops to slow compression. I'm going to give you a BVM, and do not do head tilt. Just do bad ventilations where there's no chest rise. Right? And by the way, when you guys doing this, don't be on the side of the patient, be at the head. Right? So don't, no head tilt, just squeeze the bag. Right? Nothing. Now do head tilt. Squeeze a little, yeah, there you go, right? You see how it lights up in green, right? So what this is essentially your audio-visual feedback, right? We are going to be grading you, and then depending, let's say, I can arbitrarily set this for 4 minutes, 6 minutes, so I can set this at the time frame that I'm going to test you on, right? So in the end, this machine will tell me, right, how many compressions you've done, how many ventilations you've done. There's no ambiguity, right? And so I would agree it's also harder, meaning you cannot say, I did it, because the moment I finish this, I'm going to get a report, right? So I'm going to end this, right, and it's going to tell me, right, the quality of your compressions, your ventilations, and so forth, right? Something else I want to show you guys. Don't leave it. So this is your DLS checklist, and this is your ACLS. So for you to pass and get your ACLS card, right, this is the criteria, right? So the way we determine compressions is with this feedback device, the way we determine depth, the feedback device, right? What is this chest compression fraction?
It's a ratio between compressions versus not compressions.
Okay, and so compressions versus not compressions. And you notice this fraction should be greater than 80%, right? So what happens if your fraction is less than 80%? You fail. So yes, so for this checklist, right? If your chest compression fraction is less than 80%, yeah, you don't meet the AHA criteria. More importantly, they showed those patients who get ROSC, return of circulation, and essentially get discharged from the hospital, right? Their chest compression fraction is greater than 80%. And notice it's not equal to 80%, it's greater than 80%, right? And how can we get this chest compression fraction to this number? What do we need to emphasize? What do we need to do?
Minimize the amount of time that you're not doing chest compressions, like pre-charging and getting people to rotate quickly, getting that all set up.
Okay. If I take, let's say Milan is here, if I take another one of you guys, right, and we run it for 4 minutes total time, what do you think your chest compression fraction will be right now? What do you think?
Like where we expect it to be, or what it actually?
What do you think? What do you, actual, not expect. What do you actually think is going to be?
I mean,
In the beginning it decreases as time goes on.
93.
2 people.
93. All right. Can I get another volunteer? Come on. So I'm gonna put 2 timers. We're gonna do it for 4 minutes. So the moment you say there's no pulse, right? And what you're gonna do is we're gonna say, right? You're gonna use this monitor, right? So you could run put BF. We're gonna let this go so that your compressions are still visualized, right? So what you're gonna do? So what you're gonna do is you're gonna charge it up, right? And then you're gonna defibrillate when you need to, and then you're gonna resume compressions, right? Good?
Okay.
You ready?
Yeah.
All right. So hold on, we put the timers before you guys start. So I'll put this timer here. So I'm gonna explain to you how this works so you guys understand. The moment they determine there's no pulse, one timer is gonna run until 4 minutes is up. The other timer is only gonna run when the compressions are conducted. If they stop compressions, it stops. Everybody understand? Are you guys ready? So you guys respond to a call. You have a patient
We're doing
who
30 and 2,
is
right?
unresponsive. So what are you guys gonna do first?
Is the time on
Check for
hours?
responsiveness. It's fine. No response. Check for breathing. Check for a pulse.
Give me 1 second. Let me move this forward. All right. So there is no pulse. So
All right.
first timer starts.
Cardiac arrest.
Compressions begin.
Not too fast. This to be in the green, and these two are these are 2 dots.
Don't forget, you also have your defibrillator, right? So the pads were attached.
Keep on, keep on. You can rest.
You can use it to charge it and use it there.
Keep on.
You're at a minute 36.
Keep pumping. Just one more second. Like rotate from the next.
3, 2, 1.
Good. Good. Third. Charge it.
Guys have 1 minute left.
Charge it.
Where's the oh, charge this.
Go shot.
It's charged.
Clear.
Alright, clear.
Ready.
You guys can stop. So, see, so the total time, right, we ran for 4 minutes, right? The moment they determined no pulse. And here we ran 3 minutes, 15 seconds, the time the compressions were conducted. Truly speaking, some of the compressions were not so good, so I could have like paused it where the feedback didn't show all the way, right? All the full recall, but I didn't. I ran it through. So how are we gonna get the CCF? The way we get the CCF, so it's at 315 and 4, right? So it's 315, right, over 4, so we convert this to, this is in minutes, so we convert this to seconds. So there's in 1 minute, 60 seconds, what is 4 times 6? 240 seconds, right? And 3 times 180 plus 15, 195. Everybody see what I did? Right? And then we're going to divide this, we're going to multiply this by 100 to get our chest compression fraction. Right? So let's see. What do you guys think? Are we at 80%? Yep. 81%, right? So we write, so if you look at the thing, it says greater than 80%, and we got here, right? And we write 80%, and we got 81%. Right, 81.2, I think it came out, right? So they were right on the border, and I would say if we run this for like 6 minutes, right? with the interruptions, with the little pauses, right, this number will start to decline. So what I want to show you, at 4 minutes, you're right at the border. So what can they done to have this number be greater than 80%?
Get more people.
Get more people? But how? I mean, you can get more people, but there's only one person doing CPR.
Good fire.
Huh?
If the
Minimize
monitor,
interruption, just keep pumping.
But you guys were, it seemed to me like you were minimizing interruptions.
if
Bring
the monitor was
closer.
right next to them.
I mean, you could have put the monitor down, right? But what I'm saying is what I'm looking for, I'm trying to see if your thought process, right? Like, what can I do to get my CCF as high as I can?
Better communication.
No.
Switch off.
They were quiet.
They were doing that. What I'm saying to you, if we ran it the way it is, if I added, let's say, 4 more minutes, I made this 8 minutes, I guarantee this will be below 80%.
Yeah.
But how can we get it greater than 80%?
We all gotta go to the gym with Nikolai.
No, that's nothing to do with the gym. Any guesses? Yeah. Sacrifice ventilation. Thank you. Right. So you don't sacrifice ventilations, but what can we do? But you're on the right track.
Intubate?
So you could intubate and also, right, with the excellent. Don't stop. So what you do is you do continuous compressions. You do continuous compressions, and now with the AHA guidelines, you could do it. You get 1 breath every 6 seconds, even with the BVM, with continuous compressions. And the moment you introduce your advanced airway, whether it's a king tube or LMA or intubate the patient, right? Now you have an airway, and you could ventilate 1 breath every 6 seconds, and you do continuous compressions. With continuous compressions, are there any interruptions?
No.
Right? So the only interruptions will come from switching, right? Switching, and then charging. So make sure you charge while the compressions are conducted, and switches are made right beforehand. So you say, let's say, and the best way to do this is not like, I would like you to be next on compressions, or like you on compressions. I'll say like, Adam, you're next on compressions, right? So you know, I use your name. If you don't know their names, find their names, say like, what is your name? All right, my name is Mike.
So
Mike.
when things switch, they know
Yeah,
who's doing
exactly,
it.
because somebody is on compression, somebody's not me.
Yeah.
Right, but the moment I say like, Brenda, next on compressions, you know exactly, right, who's coming, right?
So just to one more time, with the BVM, even the BVM, not
Correct.
just advanced airways.
That is correct.
1 every 6 seconds?
That is correct.
Okay.
Right? So you could use the BVM, don't stop, right? Don't stop, continuous compressions, and the moment advanced airway is there, right, like the same ratio maintains, yes.
How do you get adequate ventilation if you're pushing the air out while you're trying to use positive pressure?
So what you do is you want to make sure, that's why we emphasize the feedback, and you want to have good recoil. So you press all the way down, right, up 2 inches roughly, and then you get your hands up as you can.
So you want to push
Yeah.
when
The best way I can explain to you is when you push down, think of it like this, you push down, blood goes to heart brain. When you pull back on recoil, the heart fills. So when you push down, heart brain, when you pull back, the heart fills. You got a question? Right? So I think this is important to emphasize, because when you guys are going to start being tested on ACLS, right, and we say, all right, we got to see this on feedback device, you guys start freaking out, right? How we get this, how we get that, how we get that. So when we're going to practice, we're going to use the feedback so you guys are familiar with it. You look at your performance, right? And then this chest compression fraction, the best way to do this, I would say, you do not interrupt compressions. You can do continuous compressions, right? So that's your ACLS checklist, right? So the way the Megacode runs, so that you guys have an idea, right? They'll give you different rhythms. So you see this one has bradycardia, pulseless ventricular tachycardia, PEA, right? And I think it's, what is that? Gotta look it up, not sure. Oh, I think it might be Ross care. Huh? Post-cardiac Ross care, yeah. Post-cardiac Ross care. So, sometimes they may not make sense. What I mean by that, like, you'll say, well, how come this guy went from Brady to pulseless to PA? It doesn't make sense. It's not a, per se, the case may not make sense, but they want to see that you're providing adequate care, the right medications. You're not shocking something like pulseless electrical activity, right? So the sequence of that is maintained. So we talked about that. This is the BLS checklist, which is also going to be tested in ACLS. And then something else I wanted to go over with the algorithms. So we want that. Yes, this is the one. So they call it post-cardiac arrest care, or RUS care, right? Very good. The moment you guys get a pulse, right, pulse is back, think of it like you got a new patient. So the moment you get the pulse back, right, you got a new patient. If you got a new patient, right, we're gonna start with your patient assessment from scratch. Mental assessment, mental status, airway, breathing, circulation. Why is this important? Why do we have to obtain this mental status? Why we gotta do ABCs? So why am I saying this? Why is this important?
You want to know where the patient is so you know how to treat them, because the patient's not going to come out of a cardiac arrest 100%.
Correct. So they may still have underlying conditions, right? They may be hypotensive, they may have a STEMI, they may have other etiology that causes cardiac arrest. Also in the hospital, they do something known as temperature targeted management or cooling the patient. So you have to know, were they able to follow commands upon ROSC or they weren't, right? That's why they say here, was the patient comatose, right? Were they awake? So simple commands like open your eyes or squeeze my finger. If they're able to do it, they're able to interpret what you're saying and follow the commands. And you want to inform them because, if you intubate it and they're starting to fight with the tube and then you sedate and you bring this person to the hospital and they can't really assess them at that point with their mental status, they'll ask you, how was their baseline mental status? So that's what you are doing, right? Even though it's a little lower on the list, make sure you get their baseline mental status, get their ABCs. If there are abnormalities, you correct them, right? So maybe you didn't intubate them, maybe we're using DVM, and now you see, right, they cannot protect their airway, right? They're altered. Maybe you intubate them at that point, right? You check their breathing, check their circulation. Maybe they're very hypotensive. Maybe you need to start pressors, right? You do a 12 EKG, maybe they show you ST segment elevation. So now your transport destination changes to a STEMI cath lab facility, right? So that's why they list this. This is basically what you're doing the moment you get pulses back. So they call it ROSC, return of spontaneous circulation, right? So the reason why I bring this up is just because, right, you got pulse back, don't just say we're going to transport and that's all you do, right? Vitals every 15 minutes. That may be a good BLS answer, but that's not adequate for ALS care. Actually, to be honest with you, it's not good BLS care either, right? So this is the algorithm. We talked about the BLS algorithm, we talked about ALS algorithms, we talked about the checklist. So this station, when we're going to run it today, I'm not super worried about you guys, ordering like the drugs, ordering IVs and all that advanced area management. What I want to emphasize is I want one person to be a team leader, right? Your job is to determine the time frames when the rest began, right? Count down to 2 minutes so that you know. One tip on these monitors, right? You see how this timer starts, right? So if I turn this off completely, give it a couple of seconds to basically reset, right? The moment you turn this on and you switch this to the energy dial setting, it's going to start with 00. So you could use the timer as your start timer, for
They
example.
all do that?
Not all of them. You got to look at the manufacturers. Some of the older models may not.
Like the life back system?
The newer ones, yeah. The newer ones. So I turn this off. Let's see if we'll do that. If you do it quickly enough, it will still remember the old event, right? So you see it starts with new event, right? 00. So you could use that with your time, right? To say, okay, now whether it was 6 p.m. or 6:12 p.m. This is the time person's cardiac arrest, and you use this time, right, as your 2-minute intervals. So let's say 30 seconds out, right? You pre-charge, but you tell your crew, guys, I'm not going to shock. I'm charging it in case I need to defibrillate. And then you say, okay, add them in diastole compressions, so that they know to rotate. So then the moment it goes 59, right, 2 minutes, you say stop. You check the pulse, no pulse, right? Shockable rhythm. You go ahead defibrillate, and then you say commence CPR. Right? If it's a non-shockable rhythm, right, you check the pulse, let's say pulse is back, you disarm. Or it's non-shockable rhythm, let's say like PEA, right, and there's still no pulse, you disarm, continue CPR, right? And then once we get this going in terms of switching, right, quality CPR with the feedback device and timely shocks, right, that's the highest priority in terms of your cardiac arrest care. Then we can talk about drugs, then we can talk about, intubation and all that. You guys learned a lot of skills, right? But now to put them all together, right, we got to start with like basics first, right? Another good thing to do is if you're coming up and you're a team leader, have a little piece of paper. What I would routinely do is when I did cardiac arrest, I would print a little strip, and this would serve as my, times. What I got to record here, right? when the tube was placed, when the IV started.
Medications.
Medications,
push,
right? How many shots were given, right?
What rhythms?
Yeah. So start to get into that mind. For now, I'm not going to have you do all that because you're not there yet. But what I want you to guys get to is what time the cardiac arrest began, right? Right. What time? What the information you were told, if there's anyone there. What time CPR started, right? And then your rotations of the CPR, right? When did you rotate? 2 minutes? How many shots you gave, right? Also, good idea to write down the rhythms you have, right? So if you could do that now, for now, right, that would be good. And then when you get ROSC, right, just go through the basics, right? Mental status, ABCs, right? I'm not super worried right now for the drugs. We'll work on that once you have the sequence down. If you don't have this down, nothing else, those drugs, nothing matters. I can tell you from my personal experience working with some private companies, I would go to a call to a systematic with an EMT provider. Like in a nursing facility, the patient is in bed, the EMT is doing compressions. All the boxes are torn apart from the medic bag because the medic never went through the drugs, they don't know where anything else is. And the medic is frantic. He or she standing there doesn't know what to do, and CPR is done on the bed. So if you're in that setting, right, forget all that. Just do BLS. Get the patient off the bed, put him down, and just doing basic BLS care. Nobody's going to fault you for even doing this, right, in the initial phases. Now put it in AD mode. Get your BVM ready, right?
The patient.
You follow what I'm saying? So if you're shorthand, right, you're gonna have providers there, do BLS first, right? Once BLS is set up, patient's on the ground, CPR is being done, BVM is there, OPA is there, right? Then you could start to branch off from your ALS care. Make sense? You guys have any questions about anything?
Do most monitors print the code summary afterwards?
Yeah, you can. Yeah, absolutely. Yeah, you could, every event, every
I mean, it
push.
won't log the EPIs and everything that's
Yeah.
not done, but it.
I would not.
Zoll actually has a function on it where you can log in the message.
Does it?
Oh wow, that's cool.
Yeah. I personally never did it on the monitor. I always utilize a piece of, why? Because I want to be back.
Probably didn't change the paper.
No, I want to stay back so I can see where everyone is, what everyone is doing. I don't want to be like, I guess, like blindfold, yeah.
Kind of like the nurses in the ER. There's
You
always
want-
one in the background.
You always want to be, if you're a team leader, you cannot be doing skills, right? In the initial phases, like let's say if you coming in, yeah, you're gonna set, let's say, we both go on the call, I will intubate, right? And then I step back. And my partner, let's say, he's starting an IV and even drugs, but the moment I do my skill, let's say intubation, I step back. Because if I'm on skills, I cannot run the call, right? Any questions you guys have? No?